monthly academic session of the Asian Oceanic Society of Regional Anesthesia and Pain Medicine. It's a conglomeration of countries in the Asia-Pacific region trying to promote safe practice of regional anesthesia in our region. And every month, we allot this to a member country, and we are extremely delighted today that we have our friends from Malaysia present their thought process in two very interesting topics. One is on caudal anesthesia and adult daycare surgery, and the next one will be on physical ergonomics, a topic which is very often and very keenly discussed these days. So two very interesting topics to be presented by two experts in regional anesthesia. And I also take this opportunity to thank our board of directors from Malaysia, Dr. Shahridan Fathil, for being instrumental in making this meeting a possibility. And I'm also very happy that he does a lot of good regional anesthesia work in Malaysia. On behalf of the AOSRA Board of Directors, we thank the entire Malaysian team for the efforts that they have taken to make this webinar a possibility. And on behalf of all the Board of Directors of Asian Oceanic Society of Regional Anesthesia and the organizing team of the Academy of Regional Anesthesia of India, I welcome you all to the joint meeting of AOSRA and AORA to be held in Mumbai on the September 29th, 30th, and October 1st and 2nd. Kindly visit our website for online registrations. Now, I have great pleasure in handing over the proceedings to our Board of Directors from Malaysia, Dr. Fathil, to conduct the proceedings, including introducing the speakers of the day. Over to Dr. Fathil.
Thank you very much, Prof. Bala, for the kind introduction. And thank you very much, AOSRA-PM, for giving us, the Malaysian team, this platform for us to share our experience. I'd just like to announce there'll be a bit of a shift because Dr. Mafeitzeral Mamat, who was supposed to be scheduled as the first speaker, has got a little bit of a clinical commitment at the moment, and he'll join us as a second speaker. So there'll be a shift. Dr. Muhamad Rasydan will be the first speaker. Okay, I would like to introduce Dr. Rasydan as the first speaker. He is currently the assistant professor in the Department of Anesthesiology and Intensive Care, International Islamic University of Malaysia, based in Kuantan, which is a city on the east coast of Peninsular Malaysia. He has been a specialist since 2013, has also been a very active member of our local special interest group in regional anesthesia under the College of Anesthesiologists. He pursued a postgraduate diploma in regional anesthesia by the University of Montpellier in 2017. He has authored a number of articles, but interestingly enough, because the reason why I approached him is that he authored an article on physical ergonomics in peripheral nerve blocks. And as users of point of care ultrasound guidance, we know that this is an important topic, but it's probably not talked very much, and it's not written very much in the literature. So it is with great pleasure I would like to invite Dr. Muhamad Rasydan to deliver the talk on physical ergonomics in peripheral nerve blocks.
Thank you very much, Prof. Bala, Dr. Shahridan, and also the team. Let me share my screen now. Okay, is it okay? All right. Okay, thank you very much for the kind introduction, Dr. Shah. Okay, let's start with about physical ergonomics in regional anesthesia. I'm Dr. Muhamad Rasydan Ghani from IUM Kuantan, Pahang, Department of Anesthesia and Intensive Care. So for the talk today, I would focus on the introduction about ergonomics, the conceptual framework of physical ergonomics in peripheral nerve block, minimizing the visual spatial neural processing burden using equipment that we have, configuration, and also ergonomic needling strategy that is one of the most important. Environment principles where we need to do our PNB in an ergonomic way. The role of our assistants that sometimes we tend to forget, but they are quite important. Musculoskeletal issues where we need to maintain our neutral posture and patient positioning. Our ergonomic needling strategies that we have now, and a take-home summary from this presentation today. So as an introduction, the International Ergonomic Association has proposed the following definition of ergonomics, or human factors is the scientific discipline concerned with the understanding of interactions among humans and other elements of a system, and the profession that applies the theory, principles, data, and methods to design to optimize human well-being and overall system performance. Thus, the general approach of ergonomics is to optimize system around us while ensuring the well-being of individuals at the workplace. So the conceptual framework of physical ergonomics in peripheral nerve blocks can be divided into three. They are organizational, that is a hospital, the cognitive, and also the physical components. So for the organizational ergonomics aims to improve the patient throughout in the OT complex via multidisciplinary cooperation. Our cognitive ergonomics, where we aim to optimize the decision-making process to improve the PNB performance. And also the physical ergonomics, where we aim to improve the PNB performance through optimizing techniques and operator comfort. So the essence of physical ergonomics as applied in the context of PNB can be summarized into three significant factors. That is the brain, musculoskeletal, and also the needling technique. So the brain factor, we need to balance the visual and sensory cues with the ability to orientate and direct the needle tip to the desired location. Also, the musculoskeletal factor, the human factor, involves the operator careful planning of posture and position to optimize needle tip control and reduce physical fatigue. And also the needling factor, it focuses on selecting an effective strategy for insertion of the block needle to facilitate injection of LA to the desired target area that is surrounding the nerve. So number one is minimizing visual spatial neural processing burden using equipment configuration. So the success of every PNB that we do results from the accurate placement of local anesthetics in sufficient doses via the needle near a target nerve or in a fascial plane with no or minimal complications. So the first factor is about importance of this gaze-down viewing, where the ultrasound-guided techniques involve the simultaneous manipulation of the ultrasound probe and the block needle in 3D while looking at a 2D screen in front of you. So fine needle adjustments are necessary to achieve a good local anesthetic spread, and the image displayed on the ultrasound screen functions as a visual interface. So as you can see in the picture here, where the best procedure is done where the monitor is located in front of the operator at the level of the hands and allowing gaze down, viewing, and alignment of the visual and motor axis in front of the operator. So strategies that apply to minimally invasive surgery also applies to peripheral nerve block. The image on the ultrasound monitor screen should provide the most accurate representation of the anatomical field for a particular PNB. Thus, the proceduralist or anesthetist should ensure that the screen is adjusted so that needle movements is in vertical and horizontal axis, that is up, down, left, right, and forward or backwards, are correspondingly displayed on the monitor screen. And as you can see from the picture, the block needle should be held in the dominant hand. For example, this is a right-handed person, so on the right hand. And then it will show that superior motor competence in the dominant hand. So the ultrasound probe should be held on the non-dominant hand. So one of the new technologies that will help us to achieve this ergonomic is a head-mounted display. It's a technology that can superimpose a visual information display over the wearer's field of view. In the first description of HMD in GA, vital signs on the HMD are displayed. Will make the time reduced for visualizing anesthesia workstation, allow more of the time for direct patient surgical field monitoring. So as you can see, this is Professor Tatsuo Nakamoto, where he is wearing the HMD, and this is the image from the Epson Movirio BT30E head-mounted display. Regional blocks performed with this HMD were significantly faster and with significantly fewer head movements and attempts. The next is the visual spatial aptitude. Visual spatial and psychomotor skills are necessary for the performance of PNB. So the visual spatial aptitude is a better predictor than the psychomotor ability for the performance of ultrasound guided procedures. Even in novices or newbies, the visual spatial ability testing can predict the performance of ultrasound guided needling. One of the most possible ergonomic outcomes for visual spatial neural processing in peripheral nerve block is achieved by aligning the visual and motor axis, gaze down image display, and exact side placement of the needle image and needle entry. So this needs formal training ultrasound guided PNB, and the formal training should include this visual spatial processing and fundamental ergonomic factors. The environment practice and principles that what we do every day should take note that most of the OT temperature should be at least between 20 to 23 degrees Celsius. The relative humidity should be kept between 20% to 60%, and adequate adjustable lighting should be available. And silence is the most optimal situation while performing blocks, because noises arising from staff activities, conversations, ventilation, and anesthetic workstation should be minimized to between 40 to 80 decibel. And if there are quite loud noises, should be for short periods only. Other environment principles: a standard operating room should be the size of 38 meters squared to 55 meters squared, with adequate ventilation of 20 air changes per hour. And there should be also ample space for the ultrasound, the trolley, the operator and assistant positioned close to the patient during the PNV performance. The OT staff should don level 1 personal PPE, namely surgical face mask, apron, gloves, and eye protection while doing the procedure. And all block procedures should be carried out as aseptic procedures. And for continuous PNB, an additional sterile gown for the operator and assistant is required. So the role of assistants on the right-hand side of the operator, most our PNB performance warrant a 2% technique where the operator advances the needle while an assistant administers the injectate through an attached catheter. Ergonomically, the first assistant should be located on the dominant side of the operator, that is on the right hand, as you can see in the picture. So both the operator and assistant also should monitor the needle hub for blood during gentle aspiration before each aliquot of LA is given. And also the assistant also must observe for the expansion of intended spaces on the monitor while giving the LA. The next one of the most important part is the neutral position, also patient positioning. So we as anesthesiologists are at high risk of developing a work-related musculoskeletal disorder, that is WRMD, particularly in the neck and also our lower back. And also for the regionalis, upper limb disorders affecting the hand, arm, and neck are common among anesthesiologists. So the best prevention is neutral position, where the operator is seated on a stand or standing posture balanced around the operator's center of gravity. The operator should avoid these non-neutral postures, for example, sustained reaching, bending, twisting of the trunk, excessive neck flexion, extension rotation, and even seated or uneven standing weight distribution. Even for holding the probe, wrist flexion or extension and or deviation pinch grip could make you fatigue and you can't maintain the image for quite some time. So in this picture, the improper position where the operator is positioned with significant trunk bending and twisting, and also the operator is viewing ultrasound meter with significant neck rotation to the left, to the right, and also to the left. So all this is not an ergonomic way to do the procedures itself. It will make you tired and fatigued fast. So for the best proper position, the operator is viewing the ultrasound monitor straight ahead with a slight neck flexion, sitting down in a neutral position on the side of the block, intended block. So you can see here, most are standing on the left side, but the procedure is going to be to the right. As you can see, this is standing to the right, but the ultrasound is, you need to flex and bend the torso. So this will make you have a backache later. So even for gripping the probe, there's a way for you to grip the probe. With this improper wrist flexion and deviation position will make you fatigue and you can't hold the probe for quite a long time. Also, how do you hold it in a pinch grip position, while this one and with this one will cause muscle strain. So the best stable position to hold the probe is in a palmar grip, because it will cause less fatigue. Patient comfort and safety also must be maintained during the procedure. The patient should rest comfortably in the operating table, and access to the patient should be obstructed. So usually the best position is about supine position, and the patient position should be safe, pain-free, and ergonomic for the specific block intended. For example, if we do the erector spinal plane block or paravertebral block, the prone position is the best, but maybe the patient is placed in a lateral or sitting position if prone is uncomfortable for the patient. The regional anesthesia trolley should also be placed on the dominant side of the operator's handedness to avoid we overreach across and to get the instrument that we want to use. Next is the ergonomic needling strategy. Most of ultrasound guided PNB can be divided into out of plane, OP, and also in plane, IP approaches. Each technique has its advantages and disadvantages. The main concern for out of plane technique is the poor needle visibility, particularly of the needle tip. In contrast, the concern for in plane technique is the difficulty to maintain complete needle visibility, as this requires needle beam alignment. Needle beam alignment is the most demanding aspect of the in plane approach. The in plane approach can be further subdivided along the visual axis AL and also the cross visual axis AC. So the AL approach is associated with improved needle visualization in phantom simulations. So as you can see in the next picture, this is the along, where you can see the ultrasound monitor is in front of the operator. The probe and also transducer, so needle is along the visual axis of the operator. So this makes the needling technique much easier compared with the same procedure, but we do in a different way, where the transducer is across the procedure, despite also it's in the in-plane technique. So this technique also makes needling quite difficult sometimes. For me personally, the most procedures that we do this kind of techniques, I think in the lateral position for the erector spinal plane block is quite difficult in this position of visual axis of across. So even the needle angle is optimally inserted at the needle beam angle greater than 55 degrees for the best needle visibility in the in-plane approach. It is recommended that the operator rest their fingers or part of the hand on the patient to reduce fatigue, and this might contribute to poor needle beam alignment. Nowadays, there are numerous technologies to improve needle tip visualization, needle construction to make it echogenic, and also a bit more expensive. Ultrasound beam steering in the machine itself are also available. In one of the article by Scholter et al., needle tip design, 3D, 4D ultrasound, optical tracking, augmented reality, robotic assistance, image-based needle tracking, and also electromagnetic tracking and magnetism were discussed as part of the to enhance needle visibility and needling. Okay. This is one of the needle guidance systems that we have actually in Malaysia by Sifco Medical Solutions, where this needle guide as a physical needle guide to improve the visibility of needle at 45 angle in phantom models. So as you can see, this is the ultrasound probe, and this is the attachment outside of the probe cover, and how we do it regularly, for example, in the erector spinal plane procedures. So this is a close-up view of this physical attachment, where the attachment of there's one attachment on the probe itself, and also the other attachment outside the probe, where we put in needle, and needle is angle and also in plane technique. So this is much easier, reduce the fatigue and time of doing PNBs. So in summary, we need to optimize the balance between visual input and the cognitive capacity to orientate and respond to the combination of visual and physical feedback, careful planning of posture, position to reduce physical fatigue, and choosing an effective approach strategy for insertion of a needle block needle to achieve needle beam alignment for optimal needle visualization. So by that 3, for the first, optimize the balance visual input. So you should have the monitor located in front of the operator at the level of the hands, allowing gaze down viewing and alignment of the visual and motor axis. The image of the needle on the sound monitor is placed on the same side as the needle entry, so the position of the marker also is important on the ultrasound. The block needle is best held in dominant hand for better fine control if you're right-handed. If you're right-handed, the needle on your right hand, the ultrasound on the left, and we switch if you are left-handed. And the new technology is quite expensive. The head-mounted display has been shown to improve ergonomics by abolishing the need to view the ultrasound monitor directly in front of you. So careful planning of posture, just now mentioned, the neutral position, seated or standing posture balance around the operator's central gravity is utmost important. Avoid non-neutral postures, for example, bending, protection, wrist flexion, and the pinch grip for the probe holding. Avoid improper posture, for example, arm abduction and angle greater than 30 degrees between the torso and upper extremity. Overreaching, this will strain and make your shoulder muscles ache. You should place the ultrasound monitor straight ahead of the operator and slide 15 to 20 degrees neck flexion while viewing the monitor vertically. And all the pictures that we know that you should have vertical adjusting monitor. That will be the best. You should have the patient bed or trolley adjustable. You can go up and down. Adopt neutral wrist position while holding the probe or the block needle and resting on the patient's body or using the patient's skin for support. Utilize palmar grip for the ultrasound probe. It is firmer and less strain, and the trolley should be on your dominant side. All right. Also, the assistant also should be on your dominant side. Choosing an effective approach strategy for the block needle, probe and needle should be aligned along the visual axis with an in-plane approach where this is the AL. The needle is best inserted at the needle beam angle greater than 55 degrees for the best needle visibility in the in-plane approach. And use of physical needle guidance, echogenic needle, and also now we have echogenic catheters and ultrasound beam steering in the machine itself to improve needle visualization. So as a take-home message, now is the timeline where we are in the year 2022, where patient has more access to regional anesthesia and more anesthesiologists are trained and can perform PNB. So this ergonomics is utmost important for us to give the best and also to make the anesthesiologist less fatigued that can perform PNB in the best method to the patient itself. Thank you very much. These are some of my references. I'll stop sharing.
Thank you very much, Dr. Rasydan, for the interesting and comprehensive review on physical economics in regional anesthesia. The plan is to have the Q&A session at the end of the session. So we will get Dr. Mafiz to deliver the second talk. Dr. Mafiz, are you ready? Yes, okay. Let me introduce Dr. Mafiz. Dr. Mafeitzeral Mamat is a consultant anesthesiologist, a colleague of mine in Ghani Girls Hospital, Medini, Johor. He graduated with the Masters of Anesthesiology in 2010 from University of Malaya. He has undergone training in Royal Perth Hospital and underwent a simulation fellowship. He is also a keen volunteer with Mercy Malaysia and Maurice during disaster episodes and performed disaster anesthesia in various places. And more recently, he volunteered with MSF, Médecins Sans Frontières, during the Taliban takeover, which probably this is not the venue to actually discuss that. Recently, we also submitted an article with regards to caudal anesthesia. There was actually a demand from our urologists to actually perform caudal anesthesia for certain types of daycare urology procedure, and we have collected some data and submitted this case series for our local journal. I think with that, without further ado, I would like to invite Dr. Mafeitzeral Mamat to actually deliver the talk on caudal anesthesia for daycare, adult daycare surgery.
Okay, hi, sorry. I was looking for the unmute button, which I couldn't find at the very last minute. All right,
okay, we can hear you.
Okay, can you hear me? Okay, Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon, I presume, to all participants who are listening to this webinar at the moment. And my name is Dr. Mafeitzeral Mamat, and I'm an anesthetist in Malaysia. And I think the particular talk that we have today to be shared amongst us would be caudal anesthesia for adult daycare surgery. All right, the gist of the talk will be Basically, it's about reinventing an old trick. A bit of introduction, application, advantages, technique, and summary. For all anesthetists out there, I'm sure we are all familiar in our training, in our practice with caudal anesthesia. Basically, it's an epidural or central neuroaxial block. Perhaps those who does pediatric anesthesia would be practicing it more and a lot of this. But then again, I assume as well, some are practicing caudal anesthesia for adults, and certainly it is indicated for certain procedures that we want to do depending on what the objective and the outcome that we want to. Here, just a picture of Usain Bolt. As you know, he was and he is still the world record holder for our 100 meters. Of course, after he retired, what he did was play football. Nearly signed up for Manchester United. I wish he had, because I'm a Liverpool supporter. But in the end, he played in the Australian League, and I think he's still playing. I think recently there was a friendly that he was in. Okay, the basic thing, maybe what we are going through is the revision, but again, maybe another perspective how we can practice this particular one of the most earliest block that was one of the earliest anesthetic technique that was introduced for us all anesthetists. The caudal epidural block basically involves placing a needle through the sacral hiatus to deliver medications such as local anesthetics, steroids into the epidural space. So that's the whole idea. As you can see from that picture or the cartoon on the right side, those are the landmarks that we are to visualize because you can only see skin, and to puncture the needle there. That is like the probably traditional technique that we use, especially blind technique. It's definitely widely used in pediatrics, definitely a must, especially in the neonates and of course the younger pediatric population, but as well as in pain management, because the caudal block itself is really practiced for certain type of chronic pain that patient has. Successful blind landmark technique, however, this is mostly done and quoted for children is actually 96 to 100% success rate for children. But for adult, unfortunately, in all the literatures, they would say about 68 to only 75% for blind technique. So this is, I think, the reason why it is not particularly popular, because of certain reasons that I will go through with all of you as we go through this talk. Again, it is a simple and highly effective technique and useful for surgical procedures of the lower half of the body. Urinary tract surgeries, circumcision, hemorrhages, orthopedic surgeries on the lower limb and pelvis, depending on what we are looking to block, and operations of the anus or rectum. The indications basically for caudal block or the caudal epidural are the same as those for your lumbar epidural, nerve block, or even the thoracic, basically the epidural, because it is the epidural by anatomical epidural space, by the anatomical definition. However, the unpredictability of a certain inconsistency in the cephalate spread of the anesthetics that is administered through the caudal would limit the usefulness of this technique, especially in adults. I think those practicing pediatric anesthesia, as well as I think as a whole, we have this what we call the Armitage dosage, which was I think introduced in 1979, and perhaps become our gold standard in delivering how much volume that we want in terms of covering what level of block. For example, about 0.5 mil per kilo to L1 and up to 1.25 mil per kilo of 0.25% to 5% bupivacaine up to about T6 or high thoracic, and this is since 1979. And until now, this is the sort of like gold standard that we aim, and how I was taught during my postgraduate studies, as well as I think now those who are in the pediatric anesthesia. But this would not definitely serve for adults for this particular volume. What is interesting, I mean, just let's go through the history of all this anesthesia, especially when we talk about central neuroaxial. Maybe in 1885, first spinal puncture by Conning. And of course, after that, the intrathecal infusion of cocaine by Baer in 1895, where we would classify as the first spinal proper with local anesthetic. And then in France, 1901, the caudal epidural injection by Sicard and Kathleen. This is in France. And what is interesting, it is basically the whole idea in the beginning, it was for pain management, the chronic pain. And this is where all this starts off from in terms of delivering central neuroaxial block. And after that, we know that people use Novocaine to sciatica. And in the end, in the 1950s, where steroids has been introduced into the epidural space, and 1960 in the US, 1960s, 70s, maybe at that time we don't have proper control studies, and after 70s, our randomized control trial. So I would like to bring back to the Sikat and Kathleen in 1901. Basically, it's these two fellas, which I think if you look through the history of anesthesia, there's still controversy. It's just like Watson and Crick with DNA, so something similar with them as well. But it's particular for Kathleen, who actually introduced, as you can see in the drawing there in his paper in 1901, talking about the concept of the epidural space of these hollow tubes which is surrounding the dura. So that becomes the hallmark and the hallmark of how we reimagine the epidural space, and of course what they did is previously with their cadaver studies as well. And on the right side is Jean Chabachet in 1974, where the advancement of the epidural anesthesia for labor. So she was one of those who advocated the use of the pain management for labor pain. So that was the first or the initial part when they talk about epidural space, which is through caudal, and later on through the lumbar, and that was the history as it goes. Again, it was based on this 1944 paper. If you look at all the references on how much volume of caudal or anatomical variations, etc., was from this anatomical study in 1944. Trotter is the one which is often quoted in talking about all the anatomical layers, etc., for the caudal anesthesia, and of course the spaces that we have and what we actually refer to until today. So the advantage of caudal epidural, if we do not already know, and somehow for summary, as of course perioperative analgesia, hemodynamically stable, high patient satisfaction score, minimal disability, and fast recovery. So these are the things that we look for when we do caudal epidural. Again, when we talk about complications of caudal anesthesia, that will be directly either from the act of doing it, the injection, on where we inject it, the local anesthetic complication, and of course the adverse and exaggerated physiological responses, which becomes an issue with caudal anesthesia, which is on your upper right. If you can see, we're talking about urinary retention, a high block, or becoming a total spinal anesthesia, and of course this can also cause cardiac arrest. You have Horner syndrome. So all these things are the thing that when we talk about the physiological response, the normal complication is as per all central neuroaxial block, your subdural injection, infection causing hypotension, injury. So these are the things when we talk about doing a block. Of course, we always be aware of what complications can happen due to the block that is being performed. Okay, basically what I'm touching here is what are the evidences or what is available on literature. If you look at caudal anesthesia and you Google it up, or in any of the literature search, you would see that more towards pediatric anesthesia. So these are the few, probably this is, for example, a systematic review and meta-analysis of in 2014, which compared of course caudal block and non-caudal regional technique. This is actually comparing, looking at the inguinal block as well as the local infiltration. So obviously, I think with this, but when they're looking for the meta-analysis, definitely the superiority of caudal analgesia is there. And the thing that they say in this particular conclusion, in terms of significant risk of motor block and urinary retention, as you can see in the forest plot, for both in the motor block and urinary retention is definitely heavy. But then again, if you see all the studies that has been reviewed and taken would be from a central neuroaxial block versus a sort of like local block, the inguinal and as well as the local infiltration. So definitely you will get that this motor and urinary retention. But saying that, this is also a major issue which must be considered when we do this particular block, motor block and urinary retention. Again, I think a review in 2019 in British Journal of Anaesthesia, which talked in perspective of caudal epidural blocks, is in pediatric patients, and the review of the effectiveness as well, what are the practical considerations. I think it's worthwhile to, if you're talking about epidural, caudal epidural, this paper by Mahofer and Longquist would be an interesting read in refreshing your knowledge. Again, there is also interestingly as well, as I mentioned earlier, something regarding near the pelvic area. So epidural block for minor gynecological procedure, which is used, and this is actually a randomized control study. But again, the technique here is blind technique. So these are the previous studies in adult. So this is one of the things that we can find. And also the extent, for example, this case report, using a continuous caudal epidural. This was reported in 2013 for vaginal hysterectomy. So you know that with caudal anesthesia, you can in fact perform vaginal hysterectomy. But of course, in this patient, as you can see, a heart disease and severe spinal deformity. All right. As you can see on your left, how scoliotic it is, and patient actually is having heart failure, having an triceptor defect with a repair done, but still it's not really that improved much. So it's needing a vaginal hysterectomy. And again, the technique used here is under image intensifier. So this is where on your right side. So this is a technique. So the idea why I put it up, this case report telling us that it is possible to like a vaginal hysterectomy to do under caudal epidural. So what are the latest, or if we talk about for adults in terms of the caudal epidural? So these two recent ones, 2020 as well as in 2019, they are the one. Yep, it's with the ultrasound guided caudal epidural anesthesia for anorectal procedures, hemorrhoids, example. Anal canal surgeries, peripeneal fistula. So these are the things that recently that they are showing that, yeah, it is something effective, but again, on the objectivity. So this, I think, one paper published from India, and the other one is, I can't really remember now. Okay. And of course, the latest that recently published in Pain Therapy, comparison of ultrasound-guided caudal epidural blocks versus spinal anesthesia for anorectal surgery. But of course, this study was looking at perioperative satisfaction of patients. But this is actually the first randomized control study identifying ultrasound-guided caudal epidural block for anorectal surgery. So I guess this is somewhere, if you're looking at literatures or things to do, yeah, this is something that maybe we would like. And I guess this is also to my interest and my institution interest. Okay. The other thing we're talking about, daycare and ambulatory surgery, I think it's well established that this is something the way forward to go. There's lots of benefit, especially when we talk about cost benefit and how it is actually a growth of market of such. And of course, it is because of new development in procedures, affordability, and increase of numbers of turnover. It can be in terms of private as well as the government, in terms of what we talk about daycare surgery and for simple surgery, where you would get the best outcome for the patient as well as the cost in attending them. So the surgery, again, the benefits, faster. Okay. One of the issues in Malaysia is, I think, the insurance companies, where especially in the private sector, they're looking for procedures to be done under daycare surgery. So that is why I think there is some interest as well from the fraternity in terms of our anesthesia service to sort this out as well. Okay, my center's experience for adult Caudal. Basically, we have had this collaboration between our department and the surgery and urology, and there's an ongoing data collection. Initially, I guess it was for our hemorrhoidectomy, our even anterior resection, prostatectomy, but all this was like for the maybe a single shot block that help for anesthesia. For analgesia, post-op pain control. So this was something that we do, and initially as well is for the high-risk patients that maybe a combination of general anesthesia plus this local block. And then I guess with the urology, we are looking at, because in our center, what we do is the prostate biopsy and also RISM. RISM is I think one of the latest way in terms when we talk about resection of the prostate. In the MRI guided prostate biopsy is actually the rectal biopsy, but using MRI guided. And the thing is, with this, you can argue that maybe a short GA, or you can just perhaps just a simple block or local anesthesia is being given, or a for a prostate prostate block is given by the surgeon. But again, with this procedure itself, the sampling that is taken, the samples taken like about 15, so 15 times that patient being pop, for that, and to do it just under purely local analgesia can be a bit uncomfortable for the patient. Therefore, the consideration was patient's demographic and the comorbidities. It is, I say, a very short procedure, but what they want is for us to be able to do a lot of patients, and these patients by right after the procedure should be able to function normally. So if you know you have the thing with general anesthesia or even regional anesthesia, for example, you give spinal block, or even say you would say a sort of like we call the spinal saddle block, there will be some residues of motor block which would impair in terms of the ability or the functionality of the patient. And what they want is, again, is because of the collection of the samples. So it is about getting as many samples on the day, and at the same time to get it sent to be for the biopsy to be read. So that is a lot of issues there, and of course excellent patient satisfaction. So this is our experience and why we've actually started doing an ultrasound guided caudal anesthesia. So okay, now let's just talk about, or maybe the review of the caudal epidural anatomy. All right, so as you know, if you see the bones there, and this is what expected in terms of your landmark anatomy to understand which is the apex and the imagination where you reckon the sacral hiatus in and the levels, your sacral cornu, the palpable area, and of course your coccyx, and this is all the area. But as the individual age, we know the overlying ligaments and the cornua thicken significantly. Hence, also the sacral hiatus may be almost closed. It can be asymmetrically open and or widely open. So there are a lot of variation, especially in adults compared to the pediatric population. A few facts: the sacral canal contains the cauda equina, including the filum terminale, the spinal meninges, adipose tissues, and sacral venous flexus. Again, the volume of the sacral canal in adult average of 14.4 mils, with a range of between 9.5 to 26 mils for the caudal space. So this is based on a MRI study which was done, and hence telling us in terms of the unpredictability. And this, for example, the subjects being taken are fairly, they try to standardize, but yeah, the volume of the sacral canal averages between that. So you say about 14 to 15 mils, and that would be the volume of theoretically how much you would give in this caudal anesthesia technique. So this technique, obviously we have done, or perhaps that we know, there's the blind technique. Perhaps I believe everybody who is trained in anesthesia would be quite familiar with this. Again, the basically is by landmark identification and injection of the needle into the space. And of course, by experience, you would again would be confident enough to know that you are in the space. And of course, what do you call that? The certain marks of, say, subcutaneous injection or maybe not in the space. Second, fluoroscopy guided technique, I suppose for pain management, those who are in pain, chronic pain practice, this is something that's for maybe called gold standard, because you can exactly see where you're going, exactly where the needle is, and the spread as well with the dye if you would like to use in terms of the contrast medium. And of course, for select few, or something that maybe we do not have the facility or the luxury for fluoroscopy guided technique, or even for mobile, is the ultrasound guided technique. And this is something that maybe I will go through with all of you today in a very short presentation after this as well. So yeah, this is the three technique when we talk about caudal epidural injection. Basically, the classic blind technique requires you to position a patient in the lateral decubitus and as much as possible to expose the area between your L1 to your sacral, and of course the palpation of your posterior suprailiac spine and your sacral hiatus as well as your cornu, and to get a space there. In pediatric population, I think it is much easier because most often people do it under general anesthesia. Even if it's not under general anesthesia, it's much easier to manipulate and position themselves as such. But imagine for patients who are elderly, for example, in procedures that we do, you know that in prostate disease are the elderly males. So I'm not too sure whether it's possible really to position them in a such position for blind technique. Again, the inconsistency of the sacrococcygeal ligament can be a deterrent for us to push through, because we do not know where we are, and the last thing we want to do is having unprecedented dural injection if it's very, very deep enough. For the technique of ultrasound, I guess even in the technique of the what do you call it, the radiographic technique, we'll be in a prone position, and it is in this prone position that we expose the patient as such. And of course, the important identification or landmark is still there to understand where you would like to put your probe. Again, after patient is in position, of course, ergonomics, as my previous colleague has presented, is very, very important. And again, a needle guide, as you can see on the right side, would help to ensure the success rate, because as you know, the tendency for us to hold and for the probes to slide is easy, especially when you are at that area, or if you do your spine, sort of like a central neuroaxial block, spine, ultrasound guided for central neuroaxial techniques, and again, in this position, patient is position prone, and of course the cephalate, as you can see, and the caudal, and that is where we place our probe. And again, initial part is actually to identify your landmarks. And again, from the position of the out of plane into the in plane technique that we get for the needle to go to where we want it to be. All right. So you're asking, talking about all that. So what's the ultrasound pictures? Okay. Again, the whole reason why Kermit the Frog was the my front initial presentation is because what we look for the frog eye view. And this is at the level of the sacral cornu that you would like to find. First, for example, you would slide and put your ultrasound probe in the transverse position, and when you slide and you want to find the position where you would identify on your right upper there, almost similar like Kermit the Frog, the frog eye view. And once you get to that particular view, this is when you sort of like turn 90 degrees for the transverse view for the inline plane technique. As you can see on the left there, in the middle there, that's the bevel needle that you can visualize. And when you slide, when you turn 90 degrees, this is exactly where you are on the right down there, the area which is the between the SL is your sacrococcygeal ligament, PS or basically the base of sacrum, and CS is the corner sacrum, sacral cornu. Okay, again, the frog eye view. This is the main, as you can see on the right upper there, that is how you imagine patient prone. You would want to put that and slide and look for the picture graph that you can see, which is this view, which is the scout scan, the frog eye view. So again, you would be able to appreciate your sacral hiatus. This is the space in the middle there, and you have your sacrococcygeal ligament above and the sacral cornu, and of course the base of sacrum, which is below. Again, this is basically the video that we did, and as I slide and get that position there, and you get a very nice Kermit the Frog eyes view where you can see. And it is at this position you want to turn, or you want to 90 degrees, get your patient and ensuring where is cephalate and caudate. Okay, next slide. Sorry, not this slide. Okay, so when you get it to the position of caudate, and basically you can see the sacrococcygeal ligament and the sacral hiatus. The right top there would be the sacral cornu, and of course the base of sacrum. So when you insert the needle, this is when you insert the needle. This is actually the in the middle there. That's the bevel needle, the caudal and cephalate, the sacral hiatus, sacrococcygeal ligament, and of course the base of sacrum. All right. So okay, this is the video that we get. I think once we are in the space, and I think with any peripheral nerve block or any plane block that we have, to identify, to ensure that you see your needle all the time, especially the tip of the needle, you are aware where the space is, and when you are in the space, you would like to give your local anesthetic. So this video actually show one of the signs that you know that you are in there. There is some reverberation or movement in the epidural, in the caudal space. Let me play the video. All right. All right. If you can appreciate the needle and then the space and the initial, I'll just play the video again. Okay. And when we give, you see some reverberation. Yep. But then this would not always be the thing that you would like to find. It is good to have. I think in my limited experience, if you are in that space, you know you are confident, or you know that you are in that space, and you give that under ultrasound, it will sort of like, you will definitely, patient will have the effect, or then you can test for the dermatomas, what do you call it, the numbness, as well as the cold sensation, which has disappeared from the patient in the sacral area. So yeah, so this is one of the ways that we would know. But I guess again, is again with all blocks, you have your target, you know your area, you can see your needle, and then you can see your tip, and then you give your local anesthetic. I guess this is where the advantage, when you do it under image intensifier, you will really know where you are, because that is definitely the gold standard. Choice of local anesthetics. This would basically, you have to tailor the procedure that you want to do, whether this will be just for the analgesia at that moment of time. I think for our center, the two things that we do, the prostate biopsy as well as the rhythm. Rhythm may be slightly longer acting to be added together with the short acting, but for the MRI prostate biopsy, which takes about 30 to 45 minutes and almost up to 30 samples, yeah. So for a short acting agent. And of course, there are some desired concentration, and the volume between 15 to 20 mils. This has been as how it was quoted in the studies before, and of course with our experience. And as you can see, like I mentioned in the MRI study, the variation and the accepted average, which is about 14.4 mils. And of course, we're going to minimize the side effect if it's a central neuroexit block for motor block in spinal anesthesia. So these are examples. For example, lidocaine, 1.5% to 2%. And that is the terms of when we talk about the onset and spread and how long it would be. So again, in our center, what we've actually done, we've given lidocaine, we have given ropivacaine, and also levobupivacaine as such concentration. I think maybe I later will comment about what would be the effect. Again, the two things, there is the motor block and urinary retention. I think we maybe have some discussion on that. And what I think to our center, what was beneficial was definitely these two side effects are very minimal, and patients are definitely about 1 or 2 hours after the procedure are walking around and ready to go back and being pain-free. So that's also the whole idea, where we'll be able to do quite a number for a day and let them go back. All right, I hope I have not bore you too long. So the understanding the basics, for summary, so understanding the basics of care and combination with technology help to spur better clinical care and outcome. Caudal anesthesia under ultrasound guided technique is very doable. Everybody can block. And ambulatory care is a feasible solution to current backlogs and appropriate use of resources, especially us all post-COVID pandemic in 2020 and 2021. Okay, with that, I would say thank you very much for listening.
Thank you very much, Dr. Mafeitzeral, Mamat. I think we will open the floor to any Q&As, any comments. If I'm not mistaken, there are none yet on the chat box at the moment. Maybe Prof. Bala, may I get some comments from you?
Yeah. I take this opportunity to thank both the speakers for enumerating their particular topic in a very lucid way. Thank you so much for doing this. The first question or discussion would be on caudal and day care. Would you be doing an audit on these patients who are getting discharged, especially related to the motor weakness which can happen with this? Is there any study that has been done, especially because we don't want to have any domestic fall when they go home?
Mafiz, this is to you.
Okay, yeah, hi, yeah. As I think we've mentioned, this is something also particular. Thank you again, Dr. Bala. Okay, so, all right, thank you again. Again, yeah, definitely this is something that we are doing at the moment, and we've just collected our first sort of like a case series. We have a number and we are following up. At the moment, of course, with anything that we start and try to do, it looks good. But yes, I agree, because this is something that we would really want to avoid. But that's why in terms of what we do, especially for the current, specifically for our MRI biopsies, we're using lignocaine. So with lignocaine, within maybe say after about an hour or about 2 hours, the effect is totally went off. So patient is practically free of all this immediate effect if there is initial numbness, as well as if there was any urinary retention. And of course, yeah, at the moment, the motor block is actually fairly spared. It's like covering just the sacral area, so nothing up go to L1 or L2. But yeah, again, there are some patients who complained initially, but it was okay. But because we're using lignocaine, and I think the initial part when we mixed ropivacaine with lignocaine, it was in a way this is in study, so we are looking at all the clinical, and of course with the surgeon, because the surgeon with us, we were discussing what was the best way, because he was very keen for the patients to be discharged the same day, because some of his patients do come from quite a long way. We are a tertiary center, so when they want to do this biopsy, they come over quite far away, and he wants to discharge them back on the same day. So this is spurred the idea, and between me and even Dr. Shah, and maybe perhaps Dr. Shah would like to comment as well. But I agree, audit and have a full study on this is important, and especially this is a new experience for us as well, because we can't really find a proper reference for this, especially in adults, to really refer to and see what would be outcome. And but yeah, whatever is already there is something that we amalgate and try to formulate what we see every day.
And that's very good initiative. I think because when the surgeon wants them to send them home, and then he's very keen, and you embark on a technique which is safe and which allows the patient to have normal mobility and get back home. I think it's as you rightly said, it's a nice thought, and we look forward to more data from your case series, and possibly you will publish it and become one of the first few publications on Caudal in adults and daycare. Excellent work.
Prof. Bala, I think there are a few questions on the chat box.
Yeah.
I'm going to read from Dr. Mitra, Dr. Sharma Prasad Mitra. What percentage dose, volume, and combination of drugs used in caudal block for prostate surgery? If I may answer for Dr. Mafeitzeral, I think what we are doing right now is mainly for transperineal, MRI-guided transperineal prostate biopsy. So it's not a major prostate surgery. And the current, at least since we have learned initially, as Dr. Mafeitzeral pointed out, we were testing ropivacaine, chirocaine, and so on. But now we have stick to about 15 to 20 mils of 1.5% lignocaine. That seems to work. By limiting or nearly zero muscle weakness, and the patients can walk. Usually what happens is that they go back to daycare, and the surgeon sees the patient back in the clinic. So within a matter of a few hours, and they're discharged without any catheter. So when we started with longer acting, there were some patients who were sent back home with a catheter because they had infection. But with 1.5% lignocaine, they are discharged well without any urinary retention. Okay, another one from Nilesh Sonawani. Thank you for the talk. What are your thoughts on doing pudendal blocks, which are easier and quicker and equally effective with minimal complications for anorectal surgeries? Dr. Mafeitzeral?
No problem. If it works, and I think yeah, why not? Yeah, I think it should be done, because at the end of the day, it's the what do you call it? It's basically the hands of the skills of the anesthetist or the proceduralist. For pudendal block, sometimes the surgeon themselves are quite familiar with that. But again, when we talk here is the choices and options that we have. Definitely those who have done pudendal block 1,000 patients, they would definitely be expert, and it does work. And again, for this technique, it is something that perhaps, especially those who are in the luxury with ultrasound machine, very doable to be done, and fairly comfortable as well for all, and especially if the surgeon themselves are not sure. Again, when we talk about the transperineal biopsy, I guess there even the difference. Let me just reiterate the difference in transperineal biopsy. The usual biopsy that urologists do, maybe 1 or 2 samples. So that's why sometimes it's just enough to just local anesthetic and just pop up or even nothing, and let the patient go back home at that point of time. And again, there is also what we call the sort of prostate block, they call it, and this is being given by the surgeon with the transperineal technique before they insert for the biopsy needle. They would sort of like look anesthetic in a certain region where they see the prostate nerves are. But through the experience of our surgeon, he said that it is not really something that he said a good success rate, and that's why he had the discussion with us, because we himself looking at what he does, because we ourselves are keen regional anesthetists when we've been doing blocks, and then he's sort of like quite happy with things we do, because it looks I think that's not the right word. It makes him to be himself a good urologist in the eye of the patient, where the patient goes back and be comfortable post procedure. Yeah, but yeah, if you talk about hemorrhoids and as such, I think if we are used and in depends on where the center you are at, yeah, it would be, and it depends on when your training is. Yeah, if you're well trained, yeah, why not? Yeah, it is okay. Every technique, it works, it's safe, patient satisfied. I don't see any issue where we should limit our technique to just one.
There's a question from Dr. Amjit Vitaya Pairoch, our Thai colleague or neighbor. I think she's concerned about, I am curious about the risk of urinary retention following caudal anesthesia, especially in daycare surgery, how to avoid it. Maybe Dr. Mafis, you want to touch upon that? I think we have touched about it, about urinary retention.
Yeah, yes, that's right. Because even for caudal anesthesia, or even in pediatrics, in adults, definitely urinary retention is an issue that we like to avoid. Hence, where the choice of local anesthetic. So that's why for us, like what we want to avoid, the way we end the procedure itself, we use the short-acting lidocaine. So for us at the moment, the rate, okay, comparatively in terms of the surgeon's technique for our procedure, I'm very specific to the biopsy. The rate of urinary retention by the procedure itself is about 7-8%, kan, Dr. Shah? It's about 7%, yeah. And by us at the moment doing it with him, it is still about the same. About 7. There is about 7% of his patients, or maybe 1 or 2, having that slight of urinary retention after. Previously, we did under general anesthesia, sedation, or even spinal anesthesia. Is actually we don't really know who's the main cause if it causes urinary retention. Hence, so that's why we find that. Then that's why he sort of like quite happy that our technique would not be the thing that make him patient stay in hospital because of the urinary retention. Hence, I think that's why the choice of local anesthetic and technique, and this is something that we would definitely look into. And of course, if it's good to see if we can compare between spinal anesthesia and caudal anesthesia, which has the lower rate of urinary retention, then perhaps that would give an indication. But yeah, that is that concern, and that is something that we work closely with urologists to ensure that they do not go back with the catheter. Okay, for the other technique that we do, the RISAM. RISAM is basically using steam hot water for resection of the prostate. Patient would be kept on the catheter bladder for about a few days anyway. So for that particular procedure, we go for a slightly longer acting local anesthetic, ropivacaine or levobupivacaine. Hence, that data I wouldn't really know how to comment, because they are on the catheter itself afterwards. But for others, I think most of our patients that we do, for example, we give for analgesia, but definitely for analgesia, we give the Caudal for their laparoscopic prostatectomy. Definitely decrease usage of the PCA morphine afterwards, and the surgeon himself is quite happy for us to ensure that we do that for his patients in this particular surgery, if there's no contraindication.
Thank you very much, Dr. Mafis. Prof. Vala, back to you.
I think it was very interesting to see this, and the concept itself was very good. And this will benefit once the publication is made and we define the volume, the percentage, and the drug, and show the world that there is least complication. It's going to be extremely beneficial. I think I congratulate the team for taking and embarking into the journey of doing this, and look forward for an excellent publication from the center. And it'll be a pride to AOSRA-PM to see one of its member countries contributing to the literature in a very positive way. That was excellent session, Dr. Fathil. Thanks for putting in two nice different topics of great clinical relevance. So on behalf of, if there are no more questions, Dr. Fathil, do you want to say anything about the speakers, and how do you like to acknowledge their two talks? I think you're muted.
Thank you very much to the both speakers, to my countrymen, Dr. Rasydan and Dr. Mafeitzeral Mamat, for very excellent and very practical talks. With this, I also like to, since I think the majority of the attendants are from Malaysia, I would like to also invite everybody to the AOSRA-PM, Asian Associated Society of Regional Anesthesia and Pain Medicine meeting in Mumbai in late October, November, with Prof. Bala.
No, it's late September, October.
Late September, October.
Late, yeah.
Late September, October. Prof. Bala will be hosting us, and I think it will be an opportunity to meet a lot of the world leaders in regional anesthesia and pain medicine, and listening to new ideas. With that, I'll hand over back to Prof. Bala to conclude.
Thank you so much, Dr. Fathil, for organizing this session on behalf of the Malaysian Society to AOSRA-PM, and we had a very good participation. And I sincerely thank both the speakers, and I look forward to having all of them as a part of a meeting, the next Congress in Mumbai. And I also take this opportunity to thank Fujifilm Sonosite India for giving the platform and the technical support all the time to AOSRA-PM webinars. So until the next month, which we will announce the date and the speaker soon, bye for you, wishing you a happy time, and also making inroads into various facets of regional anesthesia. Thanks to one and all.
Thank you.
Thank you.